So we then move on to the next presentation by Datius Rweyemamu. Datius is a specialist in adolescent sexual and reproductive health with extensive research on HIV, AIDS, adolescent sexuality, media communication, and malaria, and is currently a lecturer at the University of Salaam, teaching social research methods, gender and population development, as well as sociology of sexuality. The full bios of all the panelists and speakers is part of the folder that you have. So I invite you to look at that. So Datius, please go ahead.
Thank you, Chair. I hope I'm going to spend 20 minutes and not 19 because she took 1 minute from me. Okay, I'm here to talk about help-seeking pathways and barriers for survivors. But before I talk about that, let me extend what Jacqueline has just ended with by giving a few examples about people who don't survive up to being screened. As I was asked in June to start putting together this presentation, there were some stories going on in the newspaper, in the media in Tanzania. And one of them was that there was one incident where a woman was killed by her former husband. And this husband was jailed for 5 years because of the IPV that happened between this woman and this husband. And now, after being released from jail, the first thing this man did was to contact this woman to come and have some discussion about probably how they could be building new relationship, only to find that that woman, people who managed actually to hear that that was the call, they ended up hearing that the woman was dead the next day. And if it were just a normal death, people probably could have understood. But they found that there were some funny items that were inserted in the woman's vagina, which unfortunately it was making the story bitter. But again, about 2-3 weeks ago, my fellow Tanzanians will be the eyewitnesses. About 2-3 weeks ago, there was another instance where this woman was divorced. Of course, they were still in the process of separation then, which led to divorce. And the husband went back to the in-laws to demand that he is no longer interested in this relationship. Therefore, he wants the bride price which he paid to be paid back. And the in-laws told the husband that actually it was too high and they could not be able to pay back. And after all, this woman had already given birth to several children, and that could have been the trade-off. So what this man did, he arranged where they could meet, and finally, the next day, they found this woman dead. And of course, these stories are many for the past 1, 2, 3 months. And of course, we see that some women have actually decided to come up and demonstrate in one of the regions in Western Tanzania, where and this study were conducted a few years ago. They came up and demonstrated against all these acts. But who is there to listen to them? Where did their demonstration end? Did these people survive up to the stage where they could have been screened? These are the questions that everybody who is interested in these stories in Tanzania is asking oneself, and whether these stories could be carried on like what we are hearing in South Africa about Oscar. But the legal structures, social structures are there, and we are not sure to what extent they are going to push these matters on the platform for discussions. So let me get back to my presentation. Health-seeking pathways. Next slide. Next slide. This study was purposely focusing on GBV, and it was defined by, we defined it making sure that we put this study into a context specific, and we focused on the violence perpetrated against women, and it was limited to physical sexual violence, which would have been perpetrated by the intimate partner or any other type of partner. But for this presentation, I will try as much as I can to specifically focus on the operational definition of IPB that you have been given today. Next slide. So we had 3 objectives for this study, and the first objective was to get the perceptions, the community perceptions about GBV and the related patterns. But since the presentations that we had since this morning have touched a lot about that, I'm not going to spend much time about it. And then next objective was to profile the range of services that are available for the survivors in the selected regions of Dar es Salaam, Iringa, and Tanzania, which are geographically located in almost eastern part and western part of the country. And as was pointed out by Jess in this morning presentation, Iringa and Mbeya are currently having the highest rates of HIV prevalence, and actually that was one of the reasons. I'm not underestimating one of the comments that was raised by the participant, that what is happening in the low HIV prevalence areas, but specifically this study focused on the high prevalence areas. And the third was to identify gaps and opportunities in the provision of services. I think this is where I'm going to spend much time in my talk. Next. 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 So that was the sample size. 112 key informant interviews, 12 participatory focus groups. And as you note from this slide, we looked at what Chichi was raising in the discussion, that what is happening among young men and women, and what is happening among older partners. Next. Next. So this is a list of categories of our sources of data. They range from the community leaders, local government leaders, ministerial officials, legal sector, civil society organizations, etc., etc. Next. So the results were actually categorized into 4 based on the study objectives. Next. Can I skip that because it has already been talked a lot since this morning? Okay. Maybe just a few comments about these community perceptions. In this study, we actually came up with the findings which were showing that community definitions of violence are actually categorized into 3. There are acts which communities take as acceptable, and if they're acceptable, therefore, don't talk much about them. Don't even report them, because these are part and parcel of our cultural traits. And there are actually rewards if you exercise these which are called acceptable. There are no costs. If there are costs, then they are actually increasing the value of why, if you do them, actually you are appreciated, and there is no sanctions about that. And then there are acts which were regarded as less acceptable. And these which are less acceptable, probably these are the acts which you can tell a friend, you can tell a neighbor, you can start thinking about seeking help. And those which were unacceptable, the third cycle, these are the acts which were categorized as, please, if it happens, don't waste a minute. And these were actually socially acceptable like that. But as you can see, there are some sense of overlap among the three, to some extent, that some of the things which are regarded as unacceptable, in some circumstances, they may be regarded as less acceptable, but depending on the community perceptions. Next. Next. Now, as far as the perceptions are concerned, we noticed that there is a sense of intolerance of certain acts, especially among young women. They are becoming less tolerant to the acts which older people, both young men and women, are tolerating. But in terms of understanding, or in terms of knowledge, young men seem to be more knowledgeable about GBV acts compared to the rest of the categories, including young women, older women, and older men. Next. Now, in terms of the existing services, we noted that the services range from familial to local government authority, to legal sector, legal and service sector, to the health sector. Now, starting with the family and social networks, there is a tendency of deciding which acts can be regarded as, can be treated at the family level, and which can be exposed to the to individuals' social networks. But what we noted here is that most of the GBV acts actually start being discussed at the family level. This individual thinks first about the neighbor, about the family members, before thinking of exposing anything outside the family. And next. Now the process becomes a little bit cumbersome when it comes to local government. Issues that have not been able to be resolved at the family level are expected to be pushed to the next level, which is the local government. And the local government in Tanzania has so many subcategories which are actually creating some sense of delays in the process where one would lead into accessing the services. It ranges from the 10-cell leader down to the village government, where you have the village executive officers and several committees. Next. And then you go to the ward level, where at the ward level you have the ward executive officer and you have the ward reconciliation committee. This ward reconciliation committee is working hand in hand with the ward executive officer to handle the matters, and sometimes you find that they are lacking some skills on how GBV matters must be handled, but still they will create the platform where they will spend time and send this woman back and forth before they push the matter forward. Next. And then at the district level, you have the social welfare, but all in all, at every stage that I have mentioned up to the district level there needs a referral letter. In other words, put yourself in a position of a woman who has just faced IPV, and then the first step the family has discussed and said, now, okay, you can push this matter report this to the 10-cell leader. The 10-cell leader will have to write a letter. And then he writes the letter that he is referring it to the village executive officer. And the village executive officer, once he sees that he cannot resolve the matter, will write a letter, referral letter. it goes to the ward executive officer. And the executive officer will see, with my committee, I think this is a complicated matter. So we need now to write a referral letter in order to call the Ward Reconciliation Committee. And the Ward Reconciliation Committee, after several meetings with this woman, they say, I think this matter goes it needs to be reported now to the social officer at the district level. They write a referral letter. But sometimes they say, this thing I think needs to be handled by the police. They write a referral letter. And at every stage, this woman is being asked, did you consult the previous authorities? Yes. If no, go back. Next. So in Tanzania, despite the good policies and acts that have been presented by some of the previous speakers from my country, you cannot take the matter directly to the primary district courts unless all these previous authorities have consented, something which is actually becoming a barrier. Next. Next. So at the health sector level, we have existing services from all those categories that you see from the screen. But the most important thing is that in Tanzania, it is not easy to find that at dispensary, health center, district hospitals, etc., that you can easily get the services ready-made for you. You are likely to get one type of service here, and you miss it. You are referred to the next level. You miss it. You are referred to the next level. And you cannot jump to any of these levels without actually justifying why you think it was not important for you to pass through this hierarchical order. Next. Next. Okay, now the pathways. Next, please. Okay, there is an interesting figure here, which is actually summarizing most of the slides. These are the pathways I was talking about. And the pathways are actually giving us information about what is actually happening there. Starting from the first box, we may not be able to read the content, but at least this first box is talking about the decision to seek help. How do you arrive at the decision? Before you even see, you see the people who have screened you, how do you make decisions? The decisions have criteria. The first criteria is that, is this culturally acceptable? Yes or no? What are the likely outcomes of my decision to seek help? Whom should I contact? The family. Is the family accepting? Yes or no? Whom can I involve? Maybe the friend. Is the friend reputable to give such advice? And then from there, of course, you see, those red X's are actually showing us that at every stage, there is a barrier which you have to cross. If you fail to cross it, definitely that's the end of it. So despite you see, at every spot, there are services that you are likely to get. But you have to cross all these barriers before you reach to the point where you can get these services that we are talking about. And you see, so the services from the family, from the police, from the hospital, district courts, civil society organizations, all these are actually surrounded by barriers which you have to cross. And the most, not interesting, but the most discouraging thing is that at each of these red X's, there are rules and regulations, there are norms and values which this individual has to think about before you jump to the next step. Next. So, despite the fact that the services are not many, and they are not coordinated, but they are available at different service points. These available services are underutilized. They are underutilized not because there are no people who need them, but it's because there are so many barriers to reach even those few services that are available. And, next. There are so many referral steps. There are so many referral steps and referral letters that one has to pass through, which is actually making the matters worse, because women who are in need of these services are aware of the services, are aware of the cumbersome processes that they have to pass through. And this in itself, it's not the question of what one of the participants said. We have to create awareness. Fine, you create awareness about the availability. But what about these barriers? And what should come first? That's the important thing, that's the important aspect that we have to consider. And even when we talk about the cultural barriers, yes, we have these cultural barriers, but who is talking about them? And who is the right person? Who is the right person? People from outside of a given cultural setup, or people from inside? The CBOs or the CSOs? The legal specialists or the medical specialists? At what time do we talk about them? Do we wait until a person comes in front of us for screening and that's what we regard as the right time now to start talking about them? What's the content of what we are communicating? And this is what is taking me to the last slide about the recommendations. Next, 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 next. Next, please. Next, 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 next. So these are several quotations which are actually reflecting what exactly I have been talking about. And I hope those will have chances to, okay. So this, next. We had several recommendations, but one of them is about how do we design the messages towards changing the landscape that I have presented. And whether we should talk about the physical and sexual violence, which have been said that these are taken as normal events, but now what type of message are we designing to make sure that we are catching the gist of what should be heard by those who need services and by those who are providing services? I think I should end there. Thank you.
Thank you very much, Datius Rweyemamu. Thank you for the presentation. I think for those of you who have been writing letters, you may have now to think seriously about how many levels you're writing this letter against. But I think Datius has also brought out the aspect of whose voice or whose voices as we're into this conversation. And I think it's very important that we reflect on this.